Thank you, Dr. Wong, for the introduction. And we'll just start right in. So, the main purpose of the myopia control baseline evaluation exam is to gather as much information as we can to describe the status of the eye, its refraction, as well as information about the patient. We always start off asking the patient and his or her guardian just what their goals are. And it's very obvious what their goals are, which is probably just to stop the child's prescription from advancing every year. But it is very important to hear it from them in their own words because then you can go forward with setting their expectations, which includes we cannot stop the patient's prescription from increasing, but our main objective is to slow it down so that the progression rate would not be as high as it is right now. And this is done using methods that have been studied many years and were shown to be effective. Then we figure out what the patient's daily activities include in the budget that the family is working with. This will guide us in terms of selecting which option is the most suitable for them. The exam then includes a really good manifest encyclopedic refraction. Lastly, we gather some data describing the physical measurements of the eye, such as keratometry readings and axial length measurements. So in our clinic, we mostly use the lens star. However, other modalities are available as well, such as the IOL Master or A scans. As long as it is able to quantify the length of the eye, so moving forward, you are able to use this measurement to decide if the treatment has been successful. Keratometry is also an important measurement to acquire, as you can determine if the majority of the prescription is from the corneal steepness or from a long axial length, because that can potentially change your treatment plan as well. And another benefit is that the information gathered from the scans can help you order ortho-K contact lenses if that is the treatment of choice. There are ways, including empirically ordering the contact lenses, in which you would just need to provide the consultant the patient's K values, the prescriptions, the pupil size, HVIDs, and topography maps. And more recently, there are softwares available which can directly stimulate an ortho-K lens fit on the computer. And based on the suggested lens fluorescein pattern, it can design a lens for you without any help from the consultation. That, of course, is extremely time efficient, but it does involve an investment. Lastly, there are current studies that have shown a correlation between choroidal thickness and myopia. The studies showed that the choroid is thinner by about 50 microns in higher myopes versus non-myopes. It was also shown in multiple studies that myopia control therapy does increase choroidal thickness. This applies to myopic defocus, atropine, and ortho-K. However, further investigation is needed to determine which method is the most effective. And because it is a relatively new finding, it is not yet standard of care to acquire these measurements, although it may be so in the future. With choroidal thickness, it is very variable, and so it can be altered based on diurnal shifts as well as sugar and exercise. So, because of its inconsistencies, it's very hard to measure it and incorporate it into our everyday practice. But we'll just quickly take a look here. So this is an imaging study that shows that the central choroid is thicker by about 9 microns after wearing ortho-K lenses for about a year. And it does affect the central macula a little bit more so than the parafoveal regions that we can see here.